Describe the evaluation and the management of myalgias and arthralgias in patients receiving checkpoint inhibitors. So it's important to have a background and to know what to do as far as evaluation and management of myalgias and arthralgias in patients receiving immune checkpoint inhibitor therapy. So they can complain of muscle aches or joint aches, or they may simply say they can't tell which one's which, they're just achy. So there are a variety of things that you can do to help manage that, and really what you're dealing with is chronic inflammation from the immunotherapy. Patients may present with pain or stiffness in an individual joint or multiple joints. It may be the shoulder one visit and hips and knees the next visit. So sometimes the myalgias and arthralgias will move around, and sometimes they become more generalized. Patients may have a history of a fractured ankle, and that may be the place where the arthralgias start, and it's difficult to differentiate between prior injury-related achiness and immune-related changes. So it's important to educate patients to report those changes. And a perfect example is a patient of mine that's a golfer, and now he's having difficulty grasping the golf club, and it's impacting his swing. Well, that is distinctly different than just simply having some stiffness in the joint. It's important to ask, i.e., what changes are occurring in their activities. Are they a painter? Do they do computer work? Do they climb up and down a ladder? Looking at what their life activities are and how is the therapy impacting those. Patients will often be the first to tell you it's impacting, or they may not want to tell you specifically because they don't want you to hold their therapy. So evaluation, there may be appropriate labs that can be done, and we've actually worked with our rheumatology group to identify a lab panel that we do prior to initiation of the immunotherapy, and then at whatever point patients are complaining of myalgias or arthralgias. And those include the C-reactive protein, that's a measure of inflammation, the ANA or anti-nuclear antibody, and again, that detects the presence of autoantibodies. The WSR or Westergren sedimentation rate, again, another marker of inflammation, and the rheumatoid factor. So that's a measurement of the rheumatoid factor antibody. So our rheumatology colleagues have recommended that these tests be done at baseline, and we have set them up as a lab panel. And then they can be done at the initiation or in monitoring patients throughout their course of therapy. So looking at those as options, again, we're treating patients with prior rheumatoid history or other autoimmune comorbidities, so it's important to know where they are at baseline and then have something to work with to evaluate those as patients continue on therapy. Anytime you're going to interrupt or hold an infusion of a checkpoint inhibitor, you want to repeat those rheumatology labs at that point. You want to see if any changes have occurred. X-rays are another key element in the evaluation and monitoring of patients who have complaints of joint stiffness or swelling and difficulty with mobility. Treatment would include non-steroidal anti-inflammatories, as long as they're not contraindicated, as they would be in patients with kidney cancer. So these patients are already at risk or have chronic kidney disease. So the NSAIDs are not on our list of options for therapy. Low-dose oral steroids typically will be of benefit. On a rare occasion, you may need a short course of IV steroids, during which time you've interrupted the checkpoint inhibitor, and referral to rheumatology for further management if indeed you're having difficulty with tapering the oral steroids, such that as you taper the dose, the arthralgias or myalgias flare and worsen. Then there are other alternatives for treatment as recommended by rheumatology. So they've become a very key collaborative member of our team to help manage these side effects.